Thank you, everybody, for joining us. I wanted to introduce Dr. Bo Mitchell, who is the director of our Hemostasis and Thrombosis program at the Children's Hospital Montefiore. Dr. Mitchell received his medical training at Tufts University and Boston City Hospital, which was followed by Hematology-Oncology training at Mount Sinai and Rockefeller University. He has been an attending at the New York Presbyterian and Mount Sinai hospitals, where he was the director and co-director of the Hemophilia treatment centers. Dr. Mitchell also established and directed the Platelet Biology Laboratory at the New York Blood Center for 10 years, where he worked primarily on generating platelets from stem cells. Dr. Mitchell's research and publications have focused on the basis and clinical aspects of hematology and platelet biology, and his current clinical focus is on bleeding disorders. Welcome, Dr. Mitchell, and thank you for doing the talk for us.
Thank you for having me. I'm very excited to be here. So let's get started. I'm going to talk about bleeding disorders today. So let's jump right in. So we're going to talk about inherited bleeding disorders, acquired bleeding disorders, and platelet disorders in that order. So everybody bleeds, but how much is too much? So how common is excessive bleeding? When is bleeding normal? When is it excessive? So let's go through some of those questions. So mild bleeding is very common. So 25% of people have bloody noses. And heavy menstruation is actually very common. 47% of women tend to have heavy menstrual bleeding. 20% of people have blood in their stool. 18% have easy bruising, and 18% bleed after tooth extraction. And this is normal, mild, common bleeding. So it's pretty common. So when is it excessive? It's excessive when you get bruising without trauma, when it's not in the usual distribution. So if it's on the trunk, for example, and if you get more than 5 bruises larger than a dime, usually if they're a quarter size and there's a lot of them, that's too much. Also, if the bruises are raised up, if they feel like little hematomas, that's also excessive. So we see a lot of kids for bloody nose, for epistaxis. And so we always have to decide, when is it excessive, when is it not excessive. Generally, if a bloody nose lasts longer than 10 to 15 minutes, it's excessive, it's too much. Usually it's not subtle. The nosebleeds will be an hour or 2 hours a day. And about half of patients who have bleeding disorders are going to have epistaxis. But benign epistaxis, or the usual epistaxis the kids get, is much more common than excessive epistaxis. So 25% of healthy adults have nosebleeds, but up to 40% of healthy children have nosebleeds. So it's something to keep in mind. Heavy menstrual bleeding is something that we see a lot of, and it's very frequently reported. About 1 out of 3 to 4 every young women experience heavy menstrual bleeding. It really affects quality of life. It has a negative impact on school, work, sports, other activities, and it can lead to iron deficiency, which is another reason that we see young women in the clinic. So when is menstrual bleeding heavy? We use the red flags to document heavy menstrual bleeding. So if it lasts for more than 7 days, the period, if it soaks through more than 4 or 5 products per day, if it requires doubling up of protection, getting up to change at night, experiencing gushing, or passing large clots. All of those are red flags for heavy menstrual bleeding. And so this should all be questions that you ask. The medical history is very important. The history of the hemostatic challenge of any sort will help separate patients into heavy bleeders versus normal bleeders, such as surgeries, dental extractions, etc. If there's any associated pathology that might explain the nosebleeds, like rhinitis, or if there's liver disease to explain some bruising or kidney failure, those are all important things to find out about. Also, medications are very important to find out about, especially aspirin and non-steroidal anti-inflammatories pills. So those can deactivate the platelets. Anticoagulants obviously will cause bleeding if they're in excess. Anticonvulsants, especially valproic acid, can cause platelet defects. And then herbal supplements, which I'll mention a little bit later also. So all these things can cause excessive bleeding. any family history of bleeding, low platelets, any gynecologic history of bleeding for female relatives, either severe bleeding with childbirth or after delivery, menorrhagia in any of the family members, etc. So hemostasis is basically how not to bleed. So how do you not bleed? There's two ways that your body stops bleeding, primary and secondary hemostasis. So primary hemostasis is the platelet plug formation, and secondary hemostasis is the activation of the clotting cascade. And so I'm going to talk about those two things briefly just to give some context, but I'm not going to go into great detail about it. So this is a cartoon of the primary hemostasis, which is the platelet plug formation. This is a cartoon of a blood vessel. The blood vessel is here flowing left to right. These are the endothelial cells lining the blood vessel with the extracellular membrane proteins. This is unactivated. Normal platelets are here floating through freely, minding their own business. If there's an injury to the endothelium, it activates, and the platelets will then stick to it and start rolling around and then sit down and activate. And so this is the first formation of the platelet plug. These activated platelets then are going to draw other platelets out of circulation and cause the formation of a larger and larger platelet mass. As this is happening, it's actually activating secondary hemostasis, which we'll talk about in a second, but eventually it turns into a large platelet plug that stops the bleeding. This is the coagulation cascade, which represents secondary hemostasis. I'm not going to talk too much about it other than just to focus on the middle here. This is the crux of the coagulation cascade where factor 10 is activated, and it activates thrombin and causes thrombin production, and then leads to fibrin clot formation. And I just want to show you the movie, so you don't have to read the book, you can just see the movie. This is going to be a blood vessel flowing from bottom right to upper left. The platelets are stained red, the fibrinogen is stained green, and the thrombin is blue. So you'll see all those colors as the clot progresses. So first come the platelets. You see this growth of platelets there in red. Pretty soon, you start seeing a little bit of blue inside, which is showing up as sort of a light pinkish purple. So the thrombin is deep inside the clot, and the platelets are on the outside of the clot, making the clot form. And this is going to continue basically until the vessel is occluded. So you can now see the deep blue there of all the thrombin. So let's talk a little bit about some of the bleeding disorders. So inherited bleeding disorders are the most common thing that we see in the Hemophilia Treatment Center. Let's talk about a couple of cases. So case number one, this is patient JR. She is a 16-year-old female. She presented with symptoms of dizziness and syncope. Her hemoglobin was 5.4 in the emergency department. So she was admitted. She has a history of heavy menstrual bleeding since menarche. Her menses are regular, but they do last 10 days. She changes pads every 1 to 2 hours on the heaviest days. She gets up at night to change. She soaks through no matter what she does, and she passes large clots. So if you remember, these are all red flags for heavy menstrual bleeding, and so she indeed has heavy menstrual bleeding. So we did some workup on her, and what do you imagine the diagnosis was? It's the most common thing that we see, which is von Willebrand disease. So von Willebrand disease affects any gender. It's very common. It's usually underdiagnosed. A lot of people don't know they have it. It has a very wide range of clinical severities. So some people can be very moderate and not even know that they have it. And some people can bleed very heavily, like this young woman. You get mucosal bleeding, bruising, and especially menorrhagia. So it's something that we see in the young adults with menorrhagia. The von Willebrand factor is very important because it plays a role in primary hemostasis and in secondary hemostasis. So in forming the platelet plug, it's the initial step of platelet aggregation because it makes the platelets stick to the endothelium and start the formation of the platelet plug. So it's the very beginning of the primary hemostasis. But it plays an important role in secondary hemostasis because it's the carrier of factor VIII. And it also stabilizes the clot after the clot is formed. If you get very severe von Willebrand disease and your von Willebrand factor levels are very low, your factor VIII is also going to be very low because it's the carrier of factor VIII. So basically, in von Willebrand's disease, the poor clot provides poor hemostasis. So the fibrin strands are less dense, the clots don't have mechanical strength, they fall off, they're more subject to fibrinolysis, so they don't last as long. And this is very relevant for oral bleeds, nosebleeds, and heavy menstrual bleeding, because those are the places that are affected most by these characteristics of the clot. The treatment is, there's a few different ways to treat it. One is with DDAVP or desmopressin, which releases all the von Willebrand stores. And we usually have patients get a DDAVP challenge to make sure that it works for them. It can be either IV or an intranasal spray. And both of those are very effective in type 1 von Willebrands. So there's something that we use. For more severe bleeding or unresponsive to DDAVP, we can use von Willebrand concentrates. So there's a few von Willebrand concentrates that are available for injection. So these are infused into the vein. There's also a recombinant von Willebrand factor out there for use. And these would be used in surgeries or more severe cases of von Willebrands. The other thing that we use a lot of is aminocaproic acid. It inhibits the plasminogen system, which is what breaks down the clots. So it helps clot stability. So it's really critical in achieving hemostatic success in the oral cavity, in menorrhagia, any kind of mucous membrane bleeding, it will help. The other form of this is tranexamic acid, which is same mechanism, but it's much more potent. It's about 50 times more potent than the aminocaproic acid. And it's approved for use in heavy menstrual bleeding. So it really helps with the control the flow. It's also useful for other bleeding disorders. And the dosing is here. Let's talk about another case. So this is 8-day-old male who had a bris or a circumcision. So he continued to ooze blood from the site. So they took him back. He got a stitch placed there and the bleeding stopped for a little bit. But then the next day he had more bleeding. And then the parents found a diaper full of blood and took him to the emergency department. In the emergency department, his hemoglobin was 5.4. And his factor IX level was less than 1%. So what is his diagnosis? He has hemophilia B, factor IX deficiency. So hemophilia is the loss of factor VIII, which is hemophilia A, or the loss of factor IX, which is hemophilia B. The factor VIII is about 1 in 5,000 males, and the hemophilia B is about 5 times less common, so 1 in 20,000. The estimated cases worldwide are around 400,000, probably more. And females can be symptomatic as well. In fact, females can be severe with less than 1% of factor. So don't forget to think about that when you're seeing a woman or a girl who has bleeding. The bleeding with hemophilia A and B is basically dictated by the factor level. So if the factor level is less than 1%, so there's basically no detectable factor, the bleeding, it's called severe disease, and the bleeding is usually spontaneous. Lots of abnormal bleeding after mild injuries, especially any surgery, tooth extractions. The usual age of diagnosis is very young because they typically will start bruising and bleeding frequently. And unfortunately, the most common time for intracranial hemorrhage is in the first year of life. And so unfortunately, that happens to some of these children as well, spontaneously. For the moderately severe disease with 1 to 5% of factor activity, they don't typically bleed spontaneously, but they have abnormal bleeding after minor injuries. These are usually diagnosed a few years later because they don't have the spontaneous bleeding. And then the patients with mild disease, which is greater than 5%, but up to 35, they are diagnosed usually later in life. often if they have a lot of bruising playing sports or after getting their tonsils out, that kind of thing. The factor 8 and factor 9 gene mutations are very helpful with us for different reasons. The one reason is that about 45% of patients with hemophilia A have a common mutation, which is a spontaneous inversion. The benefits of genetic testing, which we encourage our patients to get, is more effective pedigree analysis and counseling, prenatal counseling, but also inhibitor counseling, because the risk of getting an antibody against factor 8 is dependent somewhat on the genotype. The parents often ask, how did this happen? Where did this come from? Because in about a third of the cases, there's no family history. And so we have a lot of families who had never heard of hemophilia and suddenly have a child with hemophilia and are wondering what happened, where did this come from? And it's a spontaneous mutation in those cases. The signature injury of hemophilia is the joint bleed, the hemarthrosis. So this shows a knee bleed in a patient with hemophilia. You can see that it's massively swollen, it's full of blood. If this happens too many times, it really destroys the joint. You can see the loss of cartilage space, the bones become deformed, and it's very painful. The other bleeds that we worry about for people with hemophilia is intracranial bleeds, like this bleed that's shown here with the white signal. And especially in the infants, we see spontaneous intracranial bleeds. And so something that we worry about. This is something called an iliopsoas bleed. So this is a MRI section looking at from a front view. This is the normal iliopsoas muscle, and this is iliopsoas muscle full of blood. And this is it from another view, full of blood here and a normal shape there. And you can bleed enough into that that the patient can actually exsanguinate. So it's a medical emergency because it's a life-threatening bleed. Other common presentations of bleeding are GI bleeding, GU bleeding, so bloody urine, airway bleeding, and then any trauma surgery will precipitate bleeding in patients with hemophilia. The current therapy is replacement of the missing factor. In the kids, we have tried to move to prophylactic therapy as well as emergency treatment so that the kids get factor on a regular basis to increase their factor level and prevent them from bleeding. And this has been a game changer with hemophilia. We don't see the target joints that we used to see. The kids are growing up playing sports, doing all the things that their friends are doing. And so prophylaxis has really paved the way for a better life for patients. The injections are intravenous, so the parents typically learn how to infuse intravenous. And then when the kids are a little older, 8 to 10, they start learning how to infuse themselves as well. Prophylaxis generally requires 2 to 3 infusions a week, although literally a few weeks ago, a factor was approved that's a modified factor 8 that can be infused once a week. So once a week prophylaxis is pretty good. The prophylactic treatment for hemophilia B is generally once or twice a week. Also IV infusions of factor. And if started early in childhood, the joint disease can largely be prevented. The factor replacement is basically depending on what the bleed is. So with the joint bleed, basically 100% correction, a full correction of factor by infusion. The big muscle bleed, about the same, you're going to fully correct them for factor. So, so if you work in an emergency department or you're in a urgent care, these are the levels that you need to get to for joint bleed or muscle bleed. Other bleeds like mucosal bleeding or epistaxis, you can use less. A lot of people just use 100% for all of them. The most important thing is to stop the bleeding. So high triage priority. So if you're in urgent care or an emergency department, treat first and then test later. So the treat based on the history that's given even in the absence of physical signs. If the patient's coming in and saying that they're having a bleed, or if the parents think that the kid has a bleed, they probably do. The patients usually bring their clotting factor with them, and really listen to the patients and caregivers, because they always know when there's a bleed. So really give the care to what they say. So with all this, the parents ask, what is the quality of life going to be for my child, and what will they be able to do? And these days, fortunately, it's just about anything. This is Chris Bombardier. He became the first man with hemophilia to reach the summit of Mount Everest a couple of years ago. And he infused himself all the way up and all the way back down again. And nothing's stopping him from doing everything he wants to do. So recently this came along, and this is a disruptive technology. It's not a factor product, and it's really changed the face of hemophilia. It's called emicizumab, and it's actually an antibody. And it's an antibody that can be used in factor VIII deficient patients. I'm just going to show you basically what it is. This is a cartoon of factor VIII. This is factor VIII. It's a big scaffolding protein. And this is factor IX over here, and this is factor 10 over here. And this big scaffolding protein, factor VIII, brings them together so that the 9 can activate the 10. So down here is an antibody. And the two ends of the antibody bind to different things. This side binds to factor 9. This side binds to factor 10, and it brings them together so that 9 can activate 10, just like factor VIII does. So it's basically mimicking the function of factor VIII. Instead of an IV infusion once or twice a week, this is weekly to monthly subcutaneous injections. So very easy to do. No IV infusions, can be used regardless of having any antibodies against factor VIII. Very, very effective at preventing bleeding. So really changing the face of hemophilia. And coming up next is gene therapy. So factor IX gene therapy has already been approved by the FDA. Factor VIII is following closely behind. Both products are expected to be used widely by adults. They haven't been tested in children yet, but we will keep you posted. So this is a pretty exciting advancement, especially the approval of the factor IX. So let's talk about some acquired bleeding disorders. So let's do another case. So this is a 5-year-old male, otherwise well, but came to the emergency department covered with bruises all over his trunk and extremities, had petechia, and had wet purpura, which are these kind of blood blisters inside the mouth, these things. His hemoglobin was 11.2, his white blood cell was 7.6, both okay, but his platelet count was 4,000. So very, very low. So what does this patient have? Do they have leukemia, or do they have ITP? And in this case, this kid had ITP. So immune thrombocytopenia is an acquired immune-mediated disorder. It typically causes a platelet count less than 100,000. And there's an absence of any initiating or underlying cause. So it can't be in the setting of febrile illness, or it cannot be in the setting of any other cell line abnormalities. It has to be isolated thrombocytopenia on an otherwise well child. Usually there's no prodrome. There's all the bleeding symptoms you would expect for having low platelets. So ecchymosis, purpura, petechia, epistaxis, GI bleeding. Very rarely, fortunately, is intracranial hemorrhage. This doesn't typically happen in kids who are just presenting. This is typically seen in kids with chronic severe immune thrombocytopenia. And this is a blood smear just showing normal red blood cells here. And then in the center is a giant platelet. This is a really big platelet, and that's what you see in ITP. You see almost no platelets, but then the ones that are there are usually big because they're very young, because the marrow is churning them out as fast as it can. Just the classification of ITP is newly diagnosed. which is up to 3 months, and then persistent, which is 3 to 12 months. And then chronic is after 12 months. So we don't say acute and chronic anymore. We use newly diagnosed and persistent, and then chronic. ITP can also be secondary to other diseases. So if you have another underlying condition, especially an immune disease, it can cause ITP. The basic pathophysiology of it is that there are antibodies. These are my attempts to draw little antibodies. They attack the platelets, labeled conveniently in P. They attack the megakaryocytes in the bone marrow, and they cause the platelets to be destroyed by the macrophages in the liver and spleen. So it's a consumptive process, so it clears the platelets from circulation, and it's also a process of eliminating the megakaryocytes and stopping them from producing platelets. So it's an underproduction and over-destruction. The presentation is a little bit different for pediatric patients versus the adolescent patients. The incidence is about the same, 2 to 6 per 100,000. The pediatric patients, the younger ones, typically have a very abrupt onset, and so they're fine, and then they're covered with bruises and petechia. And only about 20% go on to be chronic ITP. The adolescents, on the other hand, it's much more insidious, and they'll often be diagnosed from a platelet count on a well-child check. They are fine, they have no symptoms, but they have 30,000 platelets. And more than half of these kids are going to go on to be chronic ITP patients. The first line of ITP treatment is actually observation. So if they're not bleeding, you can observe. If you need to treat, if they have active bleeding, we recommend corticosteroids first line. The other first line therapies are IVIG or intravenous anti-D. And any of these are valid for first line treatment of ITP. There's not that much of a role for platelet transfusion in a patient that's not bleeding. We'll talk about a bleeding patient in a little bit. Just to throw this up here, the corticosteroid dose is not very well standardized in the United States. It can be 2 weeks, it can be a few days. The response rate is very good, but it takes a few days to get any response, and it has all the side effects of steroids, mood swings, weight gain, etc. The immune globulin, on the other hand, acts very, very quickly. You get a response in one to 2 days. So if somebody's bleeding, you might want to consider giving them something that's going to act faster. The side effects of it, though, unfortunately, are severe headache, fever, chills, and nausea also. And then the intravenous anti-D responds pretty well. They respond very quickly within 24 hours or so, but they always get hemolysis because it is an anti-red cell antibody, and you can have you will get some hemolysis, but it can be more severe in certain people. So for emergency treatment, though, you don't want to observe. You want to stop the bleeding as quickly as possible and increase the platelet count. So basically, you're going to give all of the first-line therapies at the same time. So I would usually use corticosteroid plus IVIG or plus IV anti-D, and consider other things like the aminocaproic acid and the tranexamic acid that we were talking about before. This is where platelet transfusion comes into play. If somebody is bleeding and you give them platelets, those platelets will go to the site of bleeding and will help stop the blood flow. Stop the bleeding. So this is the time for platelet transfusion in an ITP. Just to throw it out here, the second line treatments for ITP are thrombopoietic agents, and these are mimics of thrombopoietin, and so they actually stimulate the megakaryocytes to make more platelets. So they're actually trying to overcome the decreased production, and they're very effective. The other more common second line treatment is the anti-CD20 agents. So those kill the B cells, which are the cells that are making the antibodies. There are several acquired platelet acquired states of platelet dysfunction. There are many actually: infection, liver disease, kidney failure, cardiac disease, especially cyanotic congenital heart disease. The cardiopulmonary bypass can deactivate platelets, malignancy, and there are many drugs that can also cause platelet dysfunction. So there's a lot of ways to get platelet dysfunction. There are many things that are known to cause platelet dysfunction. So aspirin, as we know, is the irreversible inhibitor of cyclooxygenase. The other non-steroidal anti-inflammatory agents, they're variable in how bad they are for platelets, but most of them will deactivate the platelets to some degree, usually reversible. Valproic acid can cause platelet problems in many ways. Can cause low platelets, can cause platelet defect, and some of the penicillins, the serotonin reuptake inhibitors can also cause platelet defect. This usually doesn't cause bleeding, but I've definitely seen some patients who have gotten better when they decrease the dose of their SSRI. And then herbal, the 4Gs. If you take garlic, ginger, ginkgo, or ginseng in pharmacologic doses, it will inhibit your platelet function. And I've seen kids bruising from getting pharmacologic doses of one of these herbs. Let's talk a little bit about platelet disorders, and I'm going to talk a little bit about what platelets are and how they're made for us, just to get an orientation. This is just to show you what platelets look like in the magnification. They look like little Ritz crackers floating around. And in this state, they're not activated, they're not sticky, they're just minding their own business. When they get activated, they shape change, they become sticky, like Velcro, and clump together, and everything sticks together. This is a picture of a megakaryocyte, which is the big cell over here on the right, and that's the cell that makes platelets in the bone marrow. It makes platelets in this, what I think is a beautiful way. It extends these long processes, and at the tips of them are all these blebs, and those little blebs are going to become the platelets, and they get filled up with granules from trafficking down all the processes. And just to see how this in action, this is the birth of a platelet. So this is a megakaryocyte, and it's turning into proplatelet processes, and you can see the platelets forming at the tips of the processes. And so the entire cell just explodes into this mass of platelet formation, and each megakaryocyte can make several thousand platelets at one time. So the clinical manifestations of platelet disorders are generally the primary hemostasis disorder. So it's an ineffective platelet plug. So you get bleeding into the skin, into the mucous membranes. You get all the skin bleeding problems that you can think of, petechia, purpura, ecchymosis, all the mucocutaneous bleeding you can think of, and particularly menorrhagia. The bleeding that's associated with hemophilia, so the deep muscle bleeds or the joint bleeds, is not common with platelet disorders. So that is a way in which they're different. So if you see somebody with skin bruising, menorrhagia, nosebleeds, think platelet disorder. The low platelets, the cause of low platelets is there are numerous ways to get low platelets. They can be decreased platelet production, and I've listed a couple of congenital problems that can cause low platelets. They can be from marrow infiltration, like leukemia, and that's always what people are worried about when they come into the emergency room covered with bruises and petechia. And they can be through infection and then drugs, like we had just talked about. They can also be low because of increased destruction. So the immune destruction is immune thrombocytopenia, like we had talked about. The alloimmune thrombocytopenia, or neonatal alloimmune thrombocytopenia that we see in the nursery, is an immune type of destruction. The non-immune types of destruction are basically mechanical. So disseminated intravascular coagulation in the hospital, Casabac Mera, which is having turbulence through vascular malformation, and then the thrombocytopenic purpura or hemolytic uremic syndrome causes destruction of the platelets. And then if the spleen is really big, like in EBV infection, the platelets get stuck in the spleen and they it causes low platelets like that. The inherited platelet disorders are vast. There are many. I used to have a nice slide with all the known mutations of platelet disorders. It was one slide, and now there are hundreds that are known. This is a cartoon of some of the more common ones that we know about, and it's divided for me into different types of ways that platelets can go wrong. So is something wrong with the stem cell itself? Is something wrong with the making the megakaryocyte make platelets, all those proplatelet formation things? Or something wrong with all the receptors, etc.? I just want to point out these up here. So these are transcription factors, and these typically don't cause the platelets to be big, just to have a low number. And so these are one of the reasons that I test for genetic deficiencies in platelets, is that these mutations, if you have mutations in these proteins, they tend to cause predisposition to leukemia. So if you have low platelets and a normal platelet size, then I would want to do genetic testing and make sure that there is no transcription factor mutation in that person, because that could lead to predisposition syndrome for leukemia. I just want to point out our Montefiore Hemophilia Treatment Center, or HTC. We have state-of-the-art management of inherited bleeding disorders, inherited clotting disorders, inherited platelet disorders, and pediatric and adult services. And I know we're a little early, but I think that's it for me. So thank you, and I'd like to answer any questions if there are.